diabetes educator, but most importantly, she is a wife to Randall and a mother to their beautiful daughter, Lillian. Ladies and gentlemen, please welcome Sally and Michelle. Take it away, Sally.
Thanks, John, and hi everyone over in the US, and good morning from Australia. I know it's about 3 or 4 in the afternoon over there, but it's about 6 a.m. Friday morning here, so good morning. And thanks very much to DM&A for having me speak this morning on an area that's really important to me and I'm really passionate about. And I think most dietitians who work in the clinical space are very passionate about also. So if we start off about why malnutrition is important, I think most of us know why malnutrition is important. Hospital malnutrition has really been established as a very critical and prevalent and costly problem, not only for patients clinically, but also for healthcare systems and around the world. And malnutrition was recognised as early as the 1970s, and there's the landmark paper that most people would know of from Butterworth, titled The Skeleton in the Hospital Closet. And to this day, we still hear malnutrition referred to as the skeleton in the hospital closet. But of course, it's not only in the hospital closet, it's in the aged care facilities, etc. as well. And that was followed closely by a couple of other papers by Bistrian et al. In the early 70s, who looked at specific cohorts of patients, surgical and general medical patients, and found the prevalence of protein energy malnutrition as high as sort of 40 to 50%. And so these might be considered some of the very first and the earliest prevalence audits in a way. And the other reason that malnutrition is getting a lot of attention lately is because we know that if patients are assessed correctly and classified and diagnosed correctly with malnutrition, that this can really have a significant impact on a patient's care and clinical costs, and therefore they need to be recognised, and there's significant reimbursement associated if those patients are coded correctly according to the ICD-10 codes. And the predominant ones that we're talking about in this regard are E43, 44, 45 and 46. And I recently sat in on the DM&A webinar around coding, which was a fantastic webinar presentation, really talking about this aspect of coding and with clinical coders. And so if we look at prevalence of malnutrition, we know that there's a global problem. It's not just in the US and it's not just in Australia, and that the prevalence around the world ranges in the literature between 20 and 60%. And I've put a number of papers listed here that talk about the prevalence, but this is by no means exhaustive. This was one that was published in Clinical Nutrition in 2008, and it really looked at a range of prospective and retrospective studies across the world. So you can see it's a problem across a number of different countries. And when they looked at all of these studies, they found the prevalence can range, as I said, between about 20 and 50%. And that's what we consistently see in the literature. This is a study that was done in my neck of the woods by Ekta Agarwal and her team as part of her PhD, and really was titled the Australasian Nutrition Care Day Survey. And it looked at over 56 hospitals across Australia and New Zealand, over 3,000 patients, and they found on average a 32% prevalence of malnutrition. And that's a figure that we see consistently in the literature. Then there's been a couple of other papers, there's been a number of other papers, but I'll talk about two here, that look at specific cohorts. And we know that certain groups of patients are more at risk than others. This one was done by Anna Boltong, who's again here in Australia in Victoria. It was published in the Australian Health Review, and found that cancer patients, certain cancer patients, the prevalence can be much higher, 50 to 80%, and that they can be up to 1.7 times more likely to be malnourished. That depends on the type of cancer, of course, but there are some cancers that are very high risk of malnutrition. And this one's another one, again, one of my colleagues here in Australia, who published in Clinical Nutrition in 2017, looked specifically at COPD patients and found they can have a much higher prevalence as well, up to 60% prevalence. And so why are we concerned about malnutrition? Well, again, there's many, many studies that have been published around this topic. And again, I haven't listed all of them. Here's a smattering of them for you. But we know that there's a significant clinical issue associated with malnutrition. We see increased readmission rates consistently reported in the literature. We know there's an increased length of stay and higher treatment costs, and there's a significant cost burden to the healthcare system. We know there's an increased risk of pressure injury if patients are malnourished. We know moderately malnourished patients are twice as likely to get a pressure injury, and severely malnourished patients can be more than 4 times likely to get a pressure injury. And we know pressure injuries are a significant cost to the organisation also. There's a higher risk of infection and falls, and we know much higher risk of complications, increased mortality, and general costs of hospital stay with malnutrition and negative outcomes. So adding on to that though, there's also what I call lost opportunity costs. So the lack of early identification and correct assessment and diagnosis of patients who are malnourished or at risk of malnutrition can lead to this lack of clinical treatment and intervention, which can be a cost, but also that lack of diagnosis and coding can really affect the reimbursement that a hospital has or gets for these patients. And there's a number of studies that have looked at this specifically as well. Again, I've just presented a few here. So if we go back to Ekta Agarwal's study, the Australasian Nutrition Care Day survey, as I said, they found an average of 32% prevalence, but they found that only 19% of those were actually coded for malnutrition. And in fact, almost 40% of hospitals didn't code any. And they found that when you do code, and this has been talked about by coding in the coding presentation as well, when they did code those patients, they saw about 20% of them shifted their diagnostic-related group or their cost weight, and there was significant revenue or reimbursement associated with that. And for this study, they found it was about $600,000 in lost reimbursement.
Sally?
This is another one, yes?
I just wanted to add, if I could, a little bit about what we're seeing across the board too, with the coding shift with malnutrition. And when we're working with hospitals in the last 9 years, we see about 12 to 15% of the time that the patients that are diagnosed with malnutrition and that gets coded, that's their only comorbidity, so thus moving the diagnostic related group. So it's a little bit lower than what you're seeing on your slide, but I would, usually middle range about 12%, but that's huge. And a lot of hospitals that we visit with before working with, or we are hearing from, they're doing part of what we're doing here is identifying assessment, but they really need to work on that physical assessment and looking at that screening process. So just adding to the opportunities there. Yeah,
absolutely. And as you say, Michelle, that percent coded again varies between different studies, and it is usually that 19% is quite high compared to some of the literature. This next paper here by Gout was done out of Royal Melbourne Hospital, again here in Australia. They found a 23% prevalence, so slightly lower prevalence, and the prevalence will change depending on the patient population, but only 15% were identified and documented, and then only 9% of those were coded. So again, we're seeing a few gaps here, not only patients being identified and documented correctly, but even if they are identified and documented, not always getting coded. And for this particular study, they worked it to be about $1.8 million in lost reimbursement. So significant dollars to the health system. This was a bigger study that looked at the Victorian health system data sets, so their whole state data sets here in Australia, for the period of 2003 to 2004. And again, they found very low rates coded, only 1.8% of patients were coded. And that malnutrition cost to the system was about $10.7 million for that year, 2003, 2004. And finally, here's one in your neck of the woods, published in the Academy Journal in 2017. And they looked at, this was the malnutrition diagnosis during adult inpatient hospitalisation analysis of a multi-institutional collaborative database of academic medical centres. And they looked at over 5.9 million hospitalisations, 105 institutions in a 2-year period, and found on average that 5% had a malnutrition diagnosis. And so if we compare that to prevalence studies and prevalent audits, we know there's a bit of a gap there. This is a really interesting study and one that I particularly like to talk about. This again was out of Melbourne here in Victoria in Australia, and it was published in the Journal of Nutrition and Metabolism in 2016. And they did a prevalence study. Sorry, it was in Canberra, in ACT, Australian Capital Territory here. They did a prevalence study and found that 53% of their patients were malnourished, which is quite a high percent of patients. And when they did their prevalence study, they found that 98% of those were coded, so very high percent were coded. But that's because they were concentrating and they did this prevalence study and identified them and documented accurately, and it went through to coding. When they looked at their usual practice, so pre that prevalence study and post that prevalence study, they found their rates of coding went down significantly. So pre was only about sort of 1 to 4% were coded. That went up slightly after their prevalence study to 4.5 to 5.5%, but nothing near what they had recorded in their prevalence audit. And so they conclude that there's something in this usual practice, the day-to-day practice and happening in hospitals and healthcare systems and their healthcare system, that was resulting in a failure to really identify, diagnose and code malnutrition. And so one of the first steps to really identifying where those gaps are can be a prevalence audit. So a prevalence audit can tell you both your prevalence of your particular patient population, as well as how many are actually being coded or captured. So it can tell you the type and the size of your issue that you have for your particular facility. It can also tell you how well you're identifying it or capturing it if you also do a coding audit. And I know Michelle does some of that as well with facilities. And then you can really start to identify where are the gaps in your process. And so if we look at the malnutrition screening and diagnosis process, this is the process at the Mathura group. So first of all patients, or eligible patients, need to be screened using a validated screening tool. We use the MST, or the malnutrition screening tool. And we aim to screen those patients within 24 hours of admission. We also screen them at 7-day intervals, and we do this because we know that the longer the length of stay of patients, the more at risk of malnutrition they are. And we know this from some of our data that we've collected over the years. Those results are documented, and then any positive screens are referred to the dietitian. The dietitian then undertakes a malnutrition assessment. And we use the PGSGA in Australia, and I know you use the Academy diagnostic criteria over there. All at-risk patients are assessed by the dietitian. We aim within 24 hours of a positive screen. And then that diagnosis and a nutrition care plan is documented. And we work very closely with our coding team to make sure that we meet their requirements that they need for coding. And those patients are then coded according to their diagnosis. And so if we look at screening and assessing, some people get confused between the two. It's important to understand the difference between the two. Screening tells you exactly who's at risk and who then needs to progress to a full assessment. Ideally, it's a quick, simple and accurate tool, validated. Ideally, can be used on large populations. Can be completed by a range of staff, but ideally trained in the tool. And I know a lot of sites use nursing to complete the risk assessment tool, screening tool. At Mathura Group, we use our dietetic assistants to do this step. And we do that because they're a relatively small group of staff that we can train up and really focus on the accuracy of delivering that tool so that we get all the correct patients screened and referred through to the dietitian. So as I said, we use the MST, the malnutrition screening tool, but there are a number of other screening tools that can be used and are used around the world. The malnutrition universal screening tool, the mini nutritional assessment short form, or the nutrition risk screen. And then the second step is the assessment. So those who have a positive screen or are deemed to be at risk then go on to full assessment. And the assessment tells you who's diagnosed and needs to be treated. Again, it's usually a longer and more comprehensive tool. It's used on the screened at-risk population. This needs to be completed by clinically trained and appropriate staff, which are most appropriately dietitians. And again, there are a range of tools. We use the PGSGA, the Patient Generated Subjective Global Assessment, but I know over there use the Academy in Asthma and Clinical Characteristics, and there are a couple of other tools as well, the Mini Nutrition Assessment, etc. And it's really important not only to use a validated tool, but also to use, when you're documenting, make sure that the documentation is appropriate for coding, because coding relies on this accurate assessment and the evidence and documentation to do accurate coding. And so at the Mathura Group Brisbane, we started this back in 2004, where we noticed exactly the problem that we've identified in the literature. We had very few patients who were being coded for malnutrition. When we looked at a year snapshot, I think we found that there were about 4 to 6 patients across our organisation that had actually been coded, which was incredibly low. And we knew from the literature with our particular patient population type that the prevalence of malnutrition was likely to be much higher than that. And so we conducted a malnutrition prevalence audit, our first one, in 2004. And we looked, as I said, at the percent, that told us the percent of our patient population that was malnourished. We looked at coding and the percent that had actually been coded prior to that. And we did the calculation with them and worked out if those patients that we diagnosed as malnourished had been coded appropriately, what were the missed dollars associated with that with reimbursement. And that was enough to convince our executive for us to implement a malnutrition screening and assessment program, which obviously took, for us at that stage, some extra resources. But the funding that was required to fund an extra dietitian and extra dietetic assistant to do the screening and the assessment was probably about a quarter to a third of the reimbursement that was brought in by that demonstrated pilot activity. And so from there, we've implemented our malnutrition screening and assessment program, and since then we've done annual prevalence audits since 2005. And these audits are really valuable to us. They tell us not only the ongoing magnitude of our problem, but also the description of the problem for our particular facility. And so what is a point prevalence audit? Really, a point prevalence can be interpreted as the amount of people who have a condition over the total amount of people in that population at a particular point in time, hence the name point prevalence. And it's expressed as a percentage, and that's why we see malnutrition prevalence expressed in the literature in that percentage, i.e. 30%. So why do you do a point prevalence audit? Well, it can be useful for several reasons. We use it to define the size of our problem. So again, we can read in the literature a lot of prevalence audits and the average prevalence of patient populations. But until we do it in our actual population, we don't know the size of our particular problem that we have at our facility. And that can then, as I said in the previous slide, define further research or funding to treat that problem. So we get an idea about the size of our problem and what funding we might need to help treat that problem. For us, it also defines the characteristics of our population, and we collect a bit of demographic data associated with the malnourished patients, which I'll talk a bit more about. And then we can monitor year on year if our prevalence has increased or decreased at subsequent prevalence audits. So how do we do a point prevalence audit? Well, essentially, it's just really replicating the malnutrition screening and assessment process. We do it on all eligible patients. So obviously, you knock out patients that aren't eligible. Pediatrics use different tools, so we do a separate pediatric prevalence audit. Not at-risk patient populations, we don't screen the maternity population, etc. And it's done on one day or at one point in time. We do it on one day, and we find that's the easiest. So again, all eligible patients are screened. Screening results are documented, referred to the positive screens referred to the dietitian. The dietitian does their assessment, diagnoses and writes the nutrition care plan, and then patients are coded according to that diagnosis. So what to consider and prepare for if you'd like to do a malnutrition prevalence audit? Well, there's a number of things you need to think about first. And the first one's probably, do you have a malnutrition screening and assessment process or program in place currently? If you do, that's great, because as I said, it's replicating that process on one day on all eligible patients. If you don't, it's probably a good idea to think about how you might implement that in terms of a prevalence audit. So things to think about: who does your screening and who does your assessment and diagnosis. As I said, different facilities use different staff to do screening. We use dietetic assistants, which are our dietitian assistant staff, because they're a small group and they're easy to train, and we can make sure that they're doing the screening, applying the screening tool correctly. Many sites use nursing, and it's part of a nurse administration tool. So it's just being aware of who does that screening, and then who's doing your assessment. And in most cases, that would be the dietitian, and we recommend that the dietitian do that. It's really important to know what your starting point is. And this is what I call your pre-data or your baseline data. And I'm always talking to my dietitians about making sure in any study they do that they get pre-data, because you can't tell the effect of your intervention post if you haven't got your pre-data. And so this is really essentially your percent coded data. And I know, as I said, Michelle does a lot of work with facilities in this space, going in and looking at what your percent coded are. And that's the also been documented well in the literature. And most commonly, it's sort of very low in that sort of 5-10% maybe. Then you need to think about what your available resources are for an audit. Again, who's going to be doing the screening and assessment, and how you can mobilise that workforce to do that, and whether you need any assistance for that. Michelle might talk more about that in a minute. How many patients are eligible, and this is how you can start to model what the workload will be to do a prevalence audit. So again, you knock out the patients that are not in your eligible population that I talked about. You can start to get an idea about how many patients you'll have to do a screen and assessment on in that day. How you identify these, this seems really simple, but you know, sometimes it's part of the work is identifying who are your eligible patients that you need to screen on, and you can use different data tools for that. We use a patient information system called TrendCare at our facility, which identifies patients who are eligible to be screened and assessed. Then you just need to think about how you'll capture that screening and assessment data. When we first started doing our point prevalence audits, this was a very manual process, and it can be done manually. We've progressed to use tablet forms to document screening and assessment data, which really has made our auditing a lot quicker and a lot easier. But again, if you're first doing the first one, you can start doing it manually. And then you need to think about how you'll analyse that data. So obviously you need to have the percent of patients that are screened, the percent that then go on to an assessment, and the percent of positive diagnoses of malnutrition there, and correlate that to your coding data. And really importantly, think about before you start, do you work with coding currently? And I would strongly recommend that you establish a relationship with coding very early on, because they're integral to this process in terms of getting your pre-data, in terms of percent coded, but also in terms of getting the post-data, percent coded post your prevalence audit. And for us, we work closely with coding after a prevalence audit to work out those that were even assessed and diagnosed and documented, if they weren't coded, why they weren't coded. And it's really important for coding as well, because we find that it's not always the documentation that's the problem. Sometimes coding just missed them. And so it's a really good awareness project for them to be involved in, to really highlight how their coding may well miss the documentation for malnutrition.
And Sally, if I could add to that.
Mm-hmm.
With the coding piece.
Sure, go ahead.
Yeah, that's okay. I know there's a bit of a delay. With the coding piece, to make sure too, when you meet with them, to understand that if you haven't already met with them and explained the Academy and Aspen clinical characteristics to identify and diagnose malnutrition, to know that they're using the clinical coding guidelines. So you want to get on the same page as them. And then when they're running the coded reports, you know, that's really important. And then going over that even monthly with them, you know, as you're doing your program. And those are all things that we work with hospitals on, but it's a place to start. I mean, and if you haven't done anything with your program, or if you're just kind of starting out, or even if you've been doing it for years, you always want to go back and keep communicating with them and just making sure that you're on the same page. And because there's always new coders and offsite coders, and there's a lot of, I don't want to say turnover, but a lot of growth in the coding arena. So thanks for letting me add that in.
Yeah, absolutely. And I would agree with that very much, Michelle. So as I said, part of the benefit of an annual prevalence audit for us is that when we touch base with coders during the year as well, but annually when we do this project, it's really highlighted gaps in coding as well. As you said, you know, sometimes there are new coders, sometimes they don't understand what they're looking for, sometimes they're just not aware of it, and so it really builds awareness in the coding space as well. So the benefits of a point prevalence audit, for us, it tells us whether we have a problem. I know we can read in the literature about prevalence in patient populations, but for us, until we did it in our own patient population, it was really only a theoretical figure. So now we have a really objective figure and objective data that tells us what our prevalence is. So do we have that? Do we have a problem? Yes or no? As I said, it tells us how big it is, our overall prevalence. It allows us to compare our results annually. Are we seeing an increase or a decrease? And we have seen over those years an increase and a decrease in different facilities within our group. And it also allows us to compare it to the literature and to the research and other comparable hospitals. As I said, if you have a high cancer population in your facility, it allows you to compare your prevalence to see how you're comparing to other hospitals. If you have a high medical or aging population, we know that those groups have a higher prevalence, etc. For us also, it allows us to see where our patient population is, where that malnourished population is, and we can look at it by facility. We have a number of different hospitals within our group. We have public and private facilities. We can see if there's a difference between those. We're organised in our organisation by clinical streams, so we can look at our streams and is there a high prevalence in different streams, and we see a high prevalence tends to be in the cancer stream, as I said, and sometimes in the medical stream. And we even collect it by ward at ward level, so we can see where that patient population is by ward and which wards have the higher prevalence. And we use this as a bit of a management tool and to manage clinical caseloads. So if a ward has particularly high prevalence, then I know the dietitian is going to get a lot of positive screens and be doing a lot of malnutrition assessments up there, and we can manage workloads that way. And as I said, we also collect a bit of demographic data on those patients that are malnourished. So it tells us what that malnourished patient population looks like. We collect age and gender, length of stay. We collect what diet type they're on. That's just a personal thing that we do for our organisation. And we time our annual prevalence audits with our annual nursing bedside safety audit, and they collect a lot of data in that audit, including pressure injury. And so because we collect at the same time, it allows us to correlate our malnutrition data with that pressure injury presence data. And again, this informs clinical management and service development. So for example, we know from our data that the elder population, as age bracket increases, malnutrition prevalence increases. So recently we had growth of our medical ward and our aged facility, and so in planning our workforce for that, we knew that there'd be likely a high prevalence of malnutrition in that group, and we could accommodate workloads accordingly. And I guess also importantly, it tells us how many patients are being missed through our current process. And as you said, what the dollars are associated with this, looking at your pre and your post data. And so in summary, we know malnutrition is common, and we know that prevalence reported globally between 20 and 60%. We know there are increased costs related to not only the complications, but length of stay and the interventions required to treat malnutrition. We certainly know that a lack of identification and treatment, and certainly lack of diagnosis and accurate coding is a missed opportunity and a reimbursement cost to the organisation, and can be significant. You know that dietitians can lead the way in really developing these structured processes for malnutrition identification, documentation, coding, and particularly auditing, I'd like to add into that mix. And we're really well placed as dietitians to develop these audit processes. Prevalence audits can really give you useful information and real data to assist to identify not only the size of your problem, but also to help you manage your problem. And audit data is really powerful, and if dietitians can lead the way in auditing and developing really clear audits and clear data, it can raise the credibility and the profile of dietitians. And we're all working in a, very much a time and a dollar-pressured healthcare environment.
Thank you, Sally, for sharing that valuable information. No, I just think about like all of us, working all over the world. We have people on here from other countries as well, so this is truly an international webinar. You over in Australia and me here in North Dakota, and I think about all of us working, and we're seeing patients. So regardless of where you are in the world, we're dealing with the same similar things. The appropriate screening, whether your diet tech is doing it or the nurse is doing it, making sure it's done correctly. And how do you know that unless you audit the process? I mean, we do a lot of coaching on finding out, like, patient by patient, if you've missed one with the data reports that we do with malnutrition, to kind of go back and find out what's going on. But what a beautiful process to do the prevalence audit, because you just do it all in one day, and it's really a time saving. Now, do you do this once a year, right? Your hospital does it once a year?
Yes, we do it annually.
Right, yep. And currently in the nutrition division, we provide a coded prevalence audit as a complementary report for any hospital interested in looking at where they are from a coded malnutrition standpoint. So when you said that 5 to 10%, that's really what we're seeing when malnutrition is coded, and it gives a good idea of what types of malnutrition are getting diagnosed, where the dietitian team is, and we also are able to give an idea, if working with us for the malnutrition education and training program, how much estimated reimbursement based on our baseline, our benchmark, that we've seen working with hospitals close to, about 9 years now. And that gives you a good idea, but the real time in the hospital gives you so much more worth. And everything that Sally has shared today is something that we can, too, help hospitals with and coach with and help facilitate and plan. So we do two different things. We do the off-site preliminary review, and that's that coded prevalence audit, where we get information from hospitals to provide them with an idea of where they are in a certain time frame with current malnutrition, and then opportunities for education and also the reimbursement tied to that, in addition to the improved quality of patient care. But then we also work with teams that we're currently working with, or we work with just to do the prevalence audit, or as part of another service we're providing them throughout the nutrition division services, where our coaches will be on site to help plan and facilitate that, whether it's a snapshot, like Sally had mentioned, for a certain unit you want to look at, or the entire hospital, depending on what the goal is of the team, and to plan how that's going to go about, what disciplines need to be involved, how the dietitians are going to facilitate that and see the patients and screen and assess, and then what to do with the results and the data, and how to move forward with education and training. More than likely, we'll go back and work with nursing and physicians and our electronic health records. So we provide coaching and education on site for that, as well as off site. And typically it would be a 1 or a 2 day visit, just depending on the size of the facility. So it's something that we're pretty excited about, and we've been providing the malnutrition education and training program to hospitals across the country for many years, and it's still a passion of ours, and we still see such a need just to even start programs. But a lot of hospitals are somewhere, they're using the clinical characteristics. They might be using just part of them and waiting on some good nutrition-focused physical assessment training on site, which we provide as well. There's a lot of webinars out there and things you can learn at conferences, and different resources from a didactic standpoint, but really to get in there and do hands-on training with your patients is really, I would like to think, of the gold standard, because how else do you learn other than with the patients and doing it while you're seeing them? And then also being able to really look at the data. And there's a lot of people that have programs that are still wondering, well, how is this impacting the severity of illness or the risk of mortality scores or the case mix index scores at my hospital, not to mention the reimbursement piece, because to be able to speak to the work that you're doing as an inpatient dietitian, to continue your program, to continue to support your job, you need to have data that supports that. And to keep your program going in that momentum, these prevalence audits are huge to really look at a program. I know hospitals have been doing malnutrition programs for well over 8 years, and probably have never done an audit like this. And so it's a great opportunity for whatever stage in the game you're at. Even if you're just starting, it'll give you even more information on that. So we're just excited to share that topic with you today. A couple other things in the nutrition division, I mentioned we do the full malnutrition education and training program, which is on-site coaching and off-site coaching and support from our DM&A team. But also we do leadership and management coaching, and then overall clinical and outpatient productivity review auditing, just looking at all the services provided and helping you to be more efficient, more effective in all areas that you work. And the management coaching piece is big, and just looking at productivity, because that gets questioned a lot too from the top. But the programs that we provide are all based on the need of the hospital. And I'm just excited, my friend, that you're able to present today and to be able to work with you and just have you share such important information on the next step, really, in the caring for malnutrition.
Great job, Sally.
Thank you.
And prevalent malnutrition audit is definitely the next vital step in any malnutrition program for improved clinical and financial benefits, definitely. At this time, we will do a Q&A session for about 15-20 minutes until the top of the hour. If you have a question for our presenters, please type it in the question box in your GoToWebinar control panel at this time, if you haven't already. Michelle, do we have any questions from the audience?
We do. We have quite a bit, so I'm excited to get started. Our first question is, are the Academy and Aspen malnutrition criteria accepted and approved criteria for diagnosing severe and moderate malnutrition by insurance payers in Australia?
That's a good question.
I don't know. That is.
So as I said, we use the PGSGA as our assessment tool. But really, in my opinion, if you look at the PGSGA, it's quite similar to the Academy characteristics. There's a physical assessment. It looks at intake and recent intake, looks at weight loss. So it's a very similar process when you're doing the assessment. Our coders look for certain documentation. They look for that a dietitian has seen them, that a dietitian has done an assessment. They look for the SGA codes, B and C. And they also look for evidence of how that assessment's been done. So similar to the Academy characteristics, they'll look for weight loss, they'll look for decreased intake, and the dietitians need to write accurate PES statements, and it has to be clear that there's also a nutrition care plan in place, that not only have we diagnosed it, but there's a care plan in place to treat it. Yeah.
Right, and that's exactly what the insurance is looking at too, to hold a code and to support it, is that the problem, the clinical validation in there, and so that PES statement supports that. A really well-written one, though, like you said, that goes over all of those areas of the characteristics, and then an intervention. So that's a good question, though. I didn't even think to ask that one. Okay, so how, this one is, how do you determine missed dollars for those patients not coded? And that's one that when we were talking about just from the coding report standpoint, so the one that we do through DM&A, the coded prevalence audit, or the preliminary review, is we're just looking at a time frame, and then we get a report of the coded malnutrition that is currently being done at your facility. And then there's calculations that we do based on our benchmarks that we've used over the last 9 years working with hospitals to do these reports. And then we just have a formula to figure it out. And it's pretty conservative. I know it's kind of probably not a very specific answer, but there's equations in there and percentages we use based on our benchmarks that we've seen in hospitals that we've worked with, that we've just done reports for. And then we provide that reimbursement piece. And it's all based on your number of MSDRG payers, so Medicare Severity Diagnosis Related Group payers, because those are the only insurance payers in the U.S. that, from a reimbursement standpoint, malnutrition is going to impact. If you have APR, or APG, APR, APG, and AP insurance payers. And those are just different types of DRG payers. You can't specifically relate the increase in dollar amount only to malnutrition because there's a bunch of different factors. So I might have lost a few people. I apologize if I throw out too many acronyms, but just remember it's your MSDRG payers. And so we take all that information and we get a lot of good information and we're able to share that with the hospitals. The next question is, who does the coding at your hospital? I think, Sally, that one probably is for you.
That's for me. So similar to the US, we have clinical coding department, so they do the coding for us, but we work closely with them to, see the patients who have been assessed as malnourished and documented and check whether they've been coded. So they run coding reports for us, and then they'll tell us who has been coded, and then we cross-match that with our prevalence audit data to see if anyone has been diagnosed by the dietitian as that we think is malnourished and we think we have documented correctly that hasn't been coded, and we'll go back to them to check why they haven't been coded. And we've just done this recently, actually, for this year, and I'm very happy to say that we find an increased number that have been coded, but also that the percent that are not coded due to a dietitian not documenting correctly has significantly decreased. Because we do this prevalence audit and we do the audit of the chart entries, and the dietitians are really aware what they have to write. So increasingly for us, the gap, the patients that haven't been coded, is coming from coding errors. Not a blame game, but that makes me happy that the dietitians are at least documenting correctly. And so it's really, as I said, it's a really good awareness project for coding as well, to know that their coders are sometimes missing. And if you don't, the old adage, if you don't know about a problem, you can't fix it. So it's really good for them too to know. But they do the coding, so we work with them.
And we should also add to, Sally, that in Australia, the dietitians, their nutrition diagnosis is a medical diagnosis, correct?
Yes, that's correct. So coding will accept a dietitian's diagnosis of malnutrition in Australia, which is great for us. I know that's a bit different over there.
It's wonderful. Yeah, no, that's wonderful.
Mm-hmm.
That's a huge part of our success, is to try to, continue. I mean, you still have to have that continuous communication and education, but that's great that you're able to have that. Speaking of physicians, we have another question just asking about, even though the dietitian is making a nutrition diagnosis of malnutrition, the physician is still refusing to make a medical malnutrition diagnosis, and what's the best way to deal with this? And that's what we really work on with our coaching. And I will both answer maybe in this one. I would first say that you have to first educate them on the what and why. So what are we focusing on, and what are the clinical characteristics? Because, most of the physicians we run into, they don't want to diagnose malnutrition because there's a bit of a fear because of all the auditing that's going on with severe protein calorie malnutrition, and nobody's educated them. So number one, you got to educate them on the clinical characteristics of malnutrition and how we get those patients. And then how does it impact them? How do we communicate that, and what are we doing for that? So we're providing that nutrition-focused physical assessment as dietitians so that they know that, they're not the ones really using those characteristics, but they know how we're using them, the nutrition experts. I mean, they surely can use them, but, 98% of the time, excuse me, we're the ones providing that assessment. We should say 100% of the time. But there are some physicians that will use that tool that we've run into over the years. But just, educating them. And always, once you've done that and you're still maybe seeing that they're not agreeing or documenting similar to you, or maybe wanting to say something different, I always like to go up and say, for example, Dr. Smith, I see you diagnosed this patient with severe protein calorie malnutrition. I also did an assessment and I found moderate protein calorie malnutrition, and this is what I found. Let's, see if we're on the same page, or am I missing something you didn't see? Or maybe they didn't see malnutrition at all and say, I found it, and this is what I used to identify it. Is there, did you see the same? In a non-accusative, hey, you should have done this kind of way, but we're like, let's get on the same page because we're both wanting to care for this patient, right? So that's kind of how one of the ways that we address it. But everybody, each physician too is individualized, and I'll say we also use physician champions of ours in hospitals if we have some tough physicians to work with. And we have some awesome ones that help out in our division that are able to speak to other physicians too if you've got some that just, would rather talk colleague to colleague. Anything you want to add to that, Sally?
No, except to say just that, in Australia, whilst they can code on a dietitian's diagnosis, we still obviously work very closely with physicians and with nursing in a multidisciplinary team. And it's been the same journey over here, an awareness campaign about what malnutrition is, how it's diagnosed, what the criteria are to diagnose it. And that's where the academy criteria is so great, and comprehensive, as a tool to demonstrate malnutrition. So it's been a similar journey here in terms of educating and getting everyone on the same page of what malnutrition is and how it's diagnosed. So, yeah.
Thank you. We have another one regarding coding. The problem with our coders at our hospital, they have albumin still as a criteria, but they haven't looked lately, but they found it a problem in the past. Well, it's still on the coding clinic guidelines as a criteria, so that's where you have to educate the coders and become their partners in this, and show them the research and articles that the Academy and Aspen have put out. And we have so many articles that support that too, that we filed away, where albumin isn't one of the defining characteristics because so many things affect it. And we actually have talking points and stuff that we use in our program specifically for the dietitian to use with physicians and coding teams, so that we can educate them well and they understand why we don't want to be querying when we find an albumin or the physician's not wanting to use it. So that's what I would speak to in there. Let's see, there's a couple other ones here. There's a lot of other ones. We've got a few more minutes, so this is good. Sally, maybe you can answer this one. I'm not positive, but we have a question about the Nutrition Day. Any thoughts to do the Nutrition Day event in the future?
Sorry, what was the question again?
The question is, any thoughts for you to do the Nutrition Day event in the future? I think it might be for you, or
is that the Australian Nutrition Care Day survey, or? Yeah,
I think it's that one. Mm-hmm. But I see that the person who asked also has left here, so okay.
Oh.
That's okay.
We don't have, that was a big study, the Australasian Nutrition Care Day survey, and it was actually a repeat of the Nutrition Care Day survey that I think was done across Europe, and I think I've presented that previously at maybe DM&A conference. So that's a huge study using multiple sites. So no, I don't have any plans to do that.
Yeah, I know. I don't either, because I think the prevalence audit just, it emphasizes so much, and it's that real-time information that speaks to the dollars and the patient care at your hospital. And I say dollars first because the next question is all about how do you present that need, the need to the administration, like the dollars saved, and how do you present that to your administration, basically your findings. And I can answer that too, but if there's anything you wanted to say about that.
No, except to say, as I said in the presentation, that's how we initially got resources to implement our malnutrition screening and assessment program. And it was that simple, it sounds simple, but it's a bit of work, calculation in terms of what percent were coded pre, what percent are actually malnourished, working with coding to do those calculations. If you add that diagnosis to their code, what the dollars are, that you'll see a difference, and just presenting it. And then it speaks for itself, I think.
Absolutely, I would agree. And when we've worked with teams too, just doing the coded prevalence piece of this and being able to tie the dollars to that along with the education and patient care, it's just making sure that each member of that administrative team or executive team, that you're speaking to what's important to them. So the operator and the finance officer, the COO and the CFO, like what's important to them. CFO dollars, COO quality of patient care, severity of illness, risk of mortality. Yes, we'd like to think everything's important to everyone, but really being just direct and matter of fact and sharing those not getting too detailed, as dietitians, we can sometimes want to share the whole story, but thinking about like just specifically, this is our findings, this is the opportunity we have, and this is how we should move forward with it, your recommendations.
And Michelle,
okay,
if I can add
go ahead.
To that.
Yeah.
Oh, sorry, just to add quickly to that, it's also, don't underestimate, the value of not, or the cost of not identifying these patients. And that sometimes speaks to the more clinical focused staff, that these patients are more at risk of pressure injuries, which cost hospital money. They have a longer length of stay if they're not treated appropriately, which costs the hospital money. So there's that cost to the hospital as well. It's not just about the reimbursement, it's about the preventative aspect and preventing those costs. Thanks.
Right. Yeah, absolutely. There's a question here about appeals and denials. I'm just going to kind of break it down. So this hospital's been having audits from insurance agencies, and they're using outdated definitions for malnutrition. We see this all the time. We have hospitals call us, even people that we've worked with, that they get audited and they might get a denial on a malnutrition code. And I know this is on the clinical nutrition managers listserv a lot through the academy, that discussion. And the thing is you just have to appeal with the information you have. And typically, each hospital has an appeals department or a denial position or a revenue integrity office. And those people, are the experts in the appeal process. And the teams that we work with, we help them with the appeals as much as we can, and just, provide recommendations, because we show them that we're using best practice. And I don't know how the insurance companies come up with some of their resources, but we have to show them that we have that diagnosis and it's based on that clinical validation. That is why it's so important that your screening tools are used well and efficiently, and that they're used correctly. Because I was just thinking about some data I looked at the other day, and there were diagnosis codes on there for severe protein calorie malnutrition, and it's some of these people the dietitian never saw. So number one, that's a red flag, because the dietitian should be seeing these patients, right, if they have malnutrition. So we'd have to go back to what happened with the screening. And a prevalence audit can definitely, capture that issue there, the problem in that. But also looking at the validation piece. So for the hospitals that are just doing intake and weight, but they're not doing the physical assessment, or they're visually doing it, or they're just doing it on some people, that is a huge part that supports your diagnosis of malnutrition, that PES statement. That's your clinical validation. You've got to do that. That's best practice. And so you have to be confident in that, because if you're not confident, you're not going to write it down, you're not going to do it. And that's where some of those, quite a few of those denials are coming from, because we just don't have enough to support that diagnosis. And granted, we're not medical diagnosing here in the US, but what all our hospitals, and we're all trying to do, is get that nutrition diagnosis, and we're bringing it to the physician, right? And so that has got to be a perfect package that we did our best, because that's a huge comorbidity, moderate and severe protein calorie malnutrition. And you can probably tell I'm pretty passionate about this. And then you have to have a good intervention. And we have to have an intervention in the inpatient setting, absolutely. But remember, these patients are coming in with malnutrition. So what's your outpatient intervention? What are you sending them home with? Who are you working with? Because that's a huge piece of it as well. So that's just kind of like, how do you appeal? Well, you make sure, number one, you have all that in order. And you've got the best practice, best training that you've had, and you're confident, your team is, that you're doing it on every single nutrition assessment patient. And then from there, you support that. Even if their guidelines are different, you support what we're using as best practice in our industry. So I think we have time for like one more question. Let me see here. Here, this one maybe Sally can help with. What MST score is considered at positive screen, and do you see patients with a score of 2 or more within 24 hours? And I think you can answer that, because you talked about it in your presentation.
Yes, yeah. So a score of 2 or more is considered at risk, and will trigger a referral to the dietitian. And we certainly have our KPIs that all positive screens with an MST of 2 or more are seen within 24 hours by the dietitian. Obviously, we don't meet that 100% KPI, But part of our other auditing process is our process audit, and it looks at how many of those we are capturing within 24 hours and why we might not be capturing them within 24 hours and what we can do about that and what practices we can change, and etc. So again, if you don't know what the problem is or how big the problem is, it's hard to address it. So we certainly aim to assess them within 24 hours. I think at our last audit we were at about 60-something% were at 24 hours, but about 80% we were capturing at some stage. So we're working on that now.
Okay, well, thank you guys for the great questions. That was really good to have many different types too. We appreciate that. Kelly, would you advance the slide one, please? Thank you. So just a few of the other services we offer at DM&A. They're a solutions provider. We have coaches that have been operation managers and operators in food service and nutrition all over the country. And we can help with operational assessments. We implement room service or room service tune-ups. We provide interim staffing for clinical nutrition managers, chefs, food service directors, and so on, and dietitians as well. We do contract to self-op implementations and assessments. We provide uniforms for your facility, and we provide Sell a Cloud solution, which is our cloud-based food service software, and much more. And all of this is to get you to the best in your department, providing the best customer service and the best patient care. And we do this all by coaching you and working with you side by side with our years of experience.
Thank you, Michelle and Sally. Great information and lively questions. That's really cool to have this much participation. Folks, if you have any immediate needs or require any support whatsoever for your department, for your business, please don't hesitate to contact us for a free consultation with Michelle or one of our many success coaches. There's absolutely no obligation to have a conversation with us. We are here to serve you and to help you be successful. By tomorrow, you will be receiving a post-webinar email from DM&A, which will contain today's presentation handout, a CEU certificate, a link to this webinar's recording, and our contact information if you have any further questions. On behalf of Sally, Michelle, and myself, thank you for attending our webinar today. Have a great rest of the day and good evening.